Thank you very much, Susan, for sharing your story. I want to thank whoever arranged this and whoever was involved for inviting me, and I particularly want to thank Dr. Leonakis for dragging me into this, because as Jennifer said, I'm not a pediatrician. I'm an adult hepatologist, and I really am scared of the parents, and that that really was an important reason to avoid pediatrics, but here I am. Luckily, some of the patients are adult. So I have several biases. We're meant to share disclosures. I like hepatology and I love coffee, and I really like hepatology a lot. I don't have any financial conflicts. And what I want to try and do with you today is to compare and contrast. I don't normally do what I'm asked, but today I'm going to try and do what I'm asked, and I'm going to try and compare and contrast standard autoimmune hepatitis with the autoimmune hepatitis we see in APS1. So to highlight some of the similarities and some of the differences. And it's a very clinical, conceptual approach. I'm not going to show you any gels. I'm not going to, although Jennifer begged me to talk about molecular biology, I said, no, I'm not going to, I'm going to keep it clinical. This is where I live. This is my home. And in the front of the, let me see if I can, yes, in the front, this is the new hospital, the new clinical center. And this is the old hospital, which is the world's largest brick building. And there's 60, 70 years of unbelievable clinical research, and I feel very privileged to be there and to be part of it. I wanted to show you that they're not just beautiful buildings in Toronto, Washington. This is the hospital this past winter with my iPhone, and that's the sunset over the parking lot. So there's some advantages to work there. So let's go to the basics now. So what is autoimmune hepatitis? We're not really sure. And I would be lying to you if I told you that we were sure. And I could give you a whole lot of information about T cells and NK T cells and interferon alpha and gamma and all sorts of things. But if I'm very honest with you, we don't really know how it all fits together. And what's really interesting is that it can be precipitated or induced by different things. So for a long time, we've known that hepatitis A sometimes leaves younger women with autoimmune hepatitis. We've known that minocycline, a drug that's commonly used for acne, can leave young women with autoimmune hepatitis. So different precipitators, different events, the concept of molecular mimicry is very important for autoimmune hepatitis and has long been thought to be a key element. But what we do know is that it's an inflammatory progressive disease of the liver. It has variable presentation, variable forms, and there's no specific test. There's two tables. I'll give you some references in a minute. One, which the table of criteria which is used in pediatrics, and there's a very complex table. You need a degree in mathematics, or at least statistics, to understand it, to come up with a score as to whether or not you have autoimmune hepatitis as an adult. I'm not going to show you that. The incidence is 1 to 2 cases per 100,000 persons per year, so it's very rare. Women are about 75, 80%, all ethnic groups, and the peak incidence is between 16 and 30 years of age. And at the bottom, if you notice, I'll give you the references. I'm mainly going to refer to two references. This is from a fantastic journal called Clinical Liver Disease. Every article is less than 1,000 words, and it's written not for hepatologists, but it's written for a primary care physician, resident sort of level. So I think for most of you who are really reasonably sophisticated, it wouldn't be a problem. And the key elements are abnormal liver enzymes and elevated immunoglobulins. And the presentations really range. Asymptomatic people, systemic illnesses with fatigue, malaise, arthralgia, acute hepatitis, fulminant hepatic failure, and cirrhosis is seen at 25% of patients with presentation. And they're very commonly systemic associations. So let's go through some of them. Thyroid disease, Sicker syndrome, rheumatoid arthritis, type 1 diabetes, vitiligo, ulcerative colitis, celiac disease are the most common. Notice there's nothing about the parathyroid, there's nothing about the adrenals. All of these are, although ulcerative colitis, celiac disease, not really autoimmune, the rest are all autoimmune diseases. The differential diagnosis is very long. In medicine, we use this term differential diagnosis. What else could it be? And the classic story is, in the old days, before they knew what hepatitis C was, it was called non-A, non-B. And one of the hardest things is to distinguish hepatitis C on liver biopsy from autoimmune hepatitis sometimes. So it really can be a challenging diagnosis. But the differential is almost all of liver disease. What about in pediatrics? It's a little bit more complex, and there's a different reference here also from clinical liver disease that I gave you, and it's written by perhaps the world authority in the field. It's more complex, and it's divided into 3 types. Type 1, again, we go back to autoantibodies. SMA positive, ANA positive, and 80% female. It's reversed. I wrote it the wrong way around. It should be female to male, 4-1. Type 2 is LKM, and liver, so this stands for smooth muscle antigen, anti-nuclear antibody, anti-liver kidney microsomal antibody, and anti-liver cytosolic antibody. In America, we don't use the 1, but in Europe, people put the 1 after typically put the 1 after those last 2 antibodies. And they're characteristic of type 2. There's a third type, autoimmune sclerosing cholangitis, which I'm not really going to talk about, is typically associated with inflammatory bowel disease and is 1-to-1 male to female. And if you look at the autoantibodies, you'll see that type 1 is 100% ANA SMA positive, and LKM is 100% in AIH2, autoimmune hepatitis type 2. Remember, these are pediatric classifications. SLA is approximately even, about 60% in both, and increased immunoglobulin G, IgG, is seen in 84-75%. So very common, and is considered a hallmark and part of the diagnostic criteria. This is one of my patients, and there are a couple of things to look at. This is for me, a very sad picture. It's perhaps the most beautiful organ in the body, invaded and destroyed by these blue cells. Do you see all these little, very intensely staining blue nuclei? These are all inflammatory cells coming in and destroying something that's very beautiful. Along here, you have what looks like a band of scar tissue, and this is confirmed on a second stain which highlights the scar tissue in blue, and this is cirrhosis. So you can see the nodule here and a nodule here, surrounded by bands of scar tissue. So remember, in classic autoimmune hepatitis, 25% of people will present with cirrhosis. So concept break. So again, from a different journal, I wanted to quote Dr. Meili Vergani. She said, AIH2 can be part of the autoimmune polyendocrinopathy candidiasis ectodermal dystrophy syndrome, which is APS1. The liver disease is present in approximately 20% of cases. So that was as of 2009. So I'm now going to switch. Everything I said up to now was general and didn't apply specifically except for the last statement to APS1. Now we're going to switch to the NIH study, and I'm going to talk and focus on the NIH study. So I wanted to start by thanking people. So Dr. Leonakis, of course, I thanked him already for the suffering and pain he has caused me. and it's been unbelievably rewarding. I also wanted to thank Dr. Wiener because for a long time she has been following patients with APS1 and managing hyperparathyroidism. The liver fellows that I've worked with, the GI fellows and liver fellows, David Chaska and Tom Simcox, the 2 infectious disease fellows, Dr. Bondici and Dr. Rose, Elise, keeps all of us on track. Yes, very much. And David Kleiner is our pathologist. But most of all, the patients, because we could really do nothing without you. And it would be impossible to learn and to grow and to develop the knowledge unless people volunteered their time, their tissue, their DNA, their colons, their livers. And that's not always easy, particularly when you're sick, to come into a research institution. So I feel very strongly that it's a privilege and a gift, and I want to express how appreciative I am to all of you for taking part and to everyone who's taken part. And perhaps that's the most important things. And if only for that opportunity, I'm grateful to be here today. So let's go to the usual things. Everyone in the study at APS1, if you want to know why I say that, you can ask Dr. Leonakis. These were consecutive patients, and they were all evaluated per protocol. Oh, and I don't think, does that project? It probably doesn't project. Actually, no, it's okay. It looks okay. So this is, I'm going to show you a couple of tables. And I know that there are a lot of numbers, but I'll talk you through it. Oops. So there were 36 patients in the study, the top line. And the first column is just what we're looking at. The second column is for the whole group. The third column are those with autoimmune hepatitis. And the last and fourth column is those without autoimmune hepatitis. And this is at the time that we saw the patient. So this is not the ALT when they were diagnosed, and this is not the age of diagnosis. So 36 patients, 16 of whom, or 44%, had autoimmune hepatitis. Remember, 1 in 100,000. 20 of them did not have autoimmune hepatitis, and that's 44 to 56%. The age was 23. The autoimmune hepatitis group was younger, 18, and most were diagnosed much earlier, 6, 7, 8, 12 years of age. 69% of the autoimmune hepatitis group were female, and 60% of the cohort were female. So that's not the usual ratio that we see. ALT was normal by our standard, but high normal. I think a young, healthy child should probably be less than 25. So 30 is probably a bit higher than it should be, but that's what the normal range is for us. And we only had 3 abnormal. So if you think about that, 3 out of 16, that's pretty good, considering all of them were on treatment. So this is a responsive disease, right? It responds to treatment, which is important. The alkaline phosphatase was a little bit higher in the autoimmune hepatitis group, but if you correct for age, because younger people have higher alkaline phosphatase, so if you correct for age, it actually was normal. Albumin, so now let me go back a step. So one of my pet peeves is doctors really not explaining to patients. So I'm going to take my own pet peeve and I'm going to explain something to you. People talk about liver function tests. So I'll tell you about my wife and myself. So I can be in a filthy mood. I didn't even pat the dog, and she says to me, take out the trash, and I'll take out the trash. Or I can be in a fantastic mood. I'm sitting on the couch with the kids on top of me and the dog, and she says, take out the trash, and I ignore her. Okay, so remember that analogy. So the ALT is the mood the liver is in. It's got nothing to do with function. Nothing. But we call it liver function test. And it's not just semantics. It's important because patients come in to me and they say, I'm dying. Why do you say that? Well, my liver function's terrible. Well, how terrible? It's 45. No, you're not dying. You're okay. It's just in a bad mood. Of course, the longer you're in a bad mood, the more likely you're going to stop functioning. But ALT and alkaline phosphatase are the mood the liver is in. In terms of function, that's the chores, taking out the trash, doing the homework, things like that, making your bed. Albumin, total bilirubin, and PT, and platelets also to an extent. So if you look, there's no difference in the albumin, there's no difference in the total bilirubin, no difference in the PT, and the platelets are slightly higher in the autoimmune hepatitis group. So functionally, this is a terrific group. No problem with function. And remember I said 25% present with cirrhosis? This doesn't look like that. This is very different. Right. So maybe milder, but I have to say these are young people. Maybe if we wait, but that's not true either because 25% present. So we don't see that here. What about the serology? I made a big fuss of going through that. So if you look at the immunoglobulins, 5 in the whole cohort had elevated immunoglobulins. That's 14%. The numbers in brackets are the percent. 3 of the autoimmune hepatitis, that's 19%, and 2 of the non-autoimmune hepatitis. ANA was only positive in 5, 2 in the autoimmune hepatitis, and 3 in the non-autoimmune hepatitis. And these other antibodies, ASMA, LKM, SLA, they were negative entirely in the whole cohort. So I don't know what that means to call people AIH2. I have to say that there are different assays for autoantibodies, and there's a lot of controversy. People measure it either on rodents. Now, I don't know who had that idea to cut up a rodent and measure human serum and test it. I don't know. Don't want to go there. But that's the gold standard. The second way is to do an ELISA or a magnetic bead assay. And I'm not sure that the results are comparable across all 3. But most of our patients have been tested for these antibodies at multiple institutions. And no one was ever positive anywhere with any of the tests. And remember I showed you I'm not going to go back, but on the previous slide that it should be 100%. That's not what we're finding. So different. What about other autoimmune disease? I told you autoimmune hepatitis strongly associated with other autoimmune disease. So I've listed all of them except for the bottom one, or different autoimmune phenomena. And you can see there's very little difference between the 2 groups. For Addison's, 81 and 85%. Hyperpara, 81 and 95%. So, okay, but that's part of the disease, the syndrome. Of course they're the same because everyone has both. Okay, well, let's look at hypothyroidism, 31 and 30%. Pernicious anemia, 25 and 20%. Pneumonitis, 13 and 15%. Hypogonadism, 13 and 15%. Alopecia, 6 and 10%. Type 1 diabetes, 13 and 5%. But small numbers, so difficult, I don't know that 13 and 5 are really different. And if you look at chronic mucocutaneous candidiasis, 88 and 90%. If we look at it in a different way, for those of you who are more visual, if we look at the first bar being the cohort, the whole group, the second bar being those with autoimmune hepatitis, and the third bar being non-autoimmune hepatitis. And if you put it all together, anyone with anything autoimmune in any way, in each of those three groups, in the whole entire cohort, it's 33.5%. In the autoimmune patients, 33%, and the non-autoimmune, 34%. So again, it's not that all the autoimmune things run together. People are very different, and it's come up a few times today. Individuals are individual. We don't understand the patterns yet. What about the biopsy? I think the biopsy is very important, and I want to take the opportunity. I know people are sometimes scared of biopsy, particularly in children, and I know biopsy has significant risk. I understand that. I do live with biopsies, but I think it's really important. This is a setting, particularly because you're going to give people medicines over the long term which potentially have significant side effects, as you heard about the diabetes. You want to be sure about the diagnosis. And there's a large differential. I showed you that slide for elevated liver enzymes. So you really, really want to be sure that somebody needs this medicine. I don't think people should get medicines unless they really need them. Care is complex enough already. So I think the biopsy becomes very important. And this is a typical biopsy, not as blue as the other one. Remember? I put them next to each other. So I understand the stains are a little bit less intense in the bottom in this patient, but still much less blue, much, much less blue. And that seems to be very typical. We have 16 biopsies from the 16 patients. The average inflammation is 9 out of 18. There's a scoring system which goes from 0 to 18, although you never see 0. Most of us probably have a 2, 3, 4 at the moment. Maximum score 18. 9 out of 18, that's moderate. And typical autoimmune hepatitis is usually well above 12. In terms of the scar tissue, the average for the group, the mean, was 1 out of 6. Scarring is ranked from 0 to 6. 6 is cirrhosis. It's a scoring system called Ishak. There are many systems, Medivir, HAI, Nodal. You hear all these different terms, but you really want to know what's cirrhosis, and cirrhosis is 6. So 1 out of 6 is very far from cirrhosis, and 0 is normal. We only had one person who was a 3 out of 6. It was mildly advanced. Can I put that together as a term? Mildly advanced. So remember, again, 25% would be a 6 in classic autoimmune hepatitis at presentation. So what can we say? I think it looks a little different. The most important thing is that clearly, autoimmune hepatitis in APS1 clearly does well with treatment. It appears to be a milder disease, but the medicines have risk. So we have a lot to learn. And I think because it's so different, it's important to begin to understand what's really going on. So we'll have to have another symposium in a couple of years. You'll have to watch this space, and hopefully we'll have worked out some of the answers. So I wanted to end with showing, this is my youngest son. A few years ago, we went to the beach, and he woke up at dawn, and he went fishing. And you can see he's caught a tiny fish. But he was so proud. He screamed, and he woke all of us up to come and see this tiny fish. So in terms of autoimmune hepatitis, I think we're just at the beginning. It's the dawn. We have a tiny fish in our hands. We know that the outcomes are good, but we've got a long way to go. We want to end up with a big fish. We want to do much better than this. We want to understand it, want to be able to deal with it far more effectively with far less toxic medicines. Again, I want to thank the patients, collaborators, and I mentioned my mentors, Drs. Liang and Hufnagel. Thank you.